guys hear me like this? Is this better than this, or does it matter?
No.
Nicer with this, okay. So, well, thank you for having me. This is actually a lot of fun in a way because I spend, most of my days talking to patients about how to reduce coronary disease or reduce their risk of cardiac issues. And a lot of it depends on medications. But there's a lot that the patients can do without pills. And, normally when I have these type of conversations, and what we're going to talk about here is stuff that I talk to patients about every day. So the nice thing about this is I can be more efficient, right? Because I can talk to everybody here at once and then you're all done, The last time I had a bigger group, and so I think that's very appropriate. The last time I spoke to a bigger group than this was when I was a resident. I presented a presentation on pacemaker allergy. So a person who had an allergy to his pacemaker, and then he had to get a gold-plated pacemaker put in. So I presented it to, I think it was about 1,000 1,000 physicians at the allergy conference. So it's a bunch of immunologists and allergists. And I sort of said that the only thing that's rarer than a pacemaker allergy is a cardiologist speaking to a bunch of allergy doctors, right? This at least makes more sense, okay? So just to talk to start, and I'll just direct this as I go, but I hail from Newfoundland, so I grew up there. I did my undergrad and my med school. That's the big church there, the Basilica. I always wondered why it was so big until I realized that you had to pay to do penance. And then after I graduated in 1999, and then I went to Kingston. And at Kingston General Hospital, I did cardiology after I did 3 years of medicine. So I spent 6 years there. And while I was there, I met Dr. Kafka, who recruited me to Belleville. So he basically gave me an offer I couldn't refuse. And I joined actually Dr. Campbell, who just started a year before me. And there was Dr. Cortland and Dr. Link. And about 10 years after that, Dr. Kafka retired, and we were lucky enough to get Dr. Curran. So now there's 5 of us, and there we go. So here's Belleville. So I thought maybe all I really need to do if we're talking about coronary disease was just say, like pain, tightness, shortness of breath, and we're done, right? It's the angina monologues, and it's all good. But that's not really what I wanted to talk about. I mean, cardiology is a pretty intensive area. We deal with fast heart rates, slow heart rates, blocked arteries that are too big, valve problems, hearts that don't work very well or are too small. And you could read a compendium like this of Braunwald's heart disease, which is actually amongst the greatest cure for insomnia, by the way. Just let you know, right?
I'll note that.
I'll send you my copy. Right?
Okay, appreciate that.
But what I thought about today was, what would be good to talk to you guys about today? And we could talk about medications, right? Different pills and the way they work and this and that, but I'm not sure that's very interesting because, first of all, that many of the pills don't apply to every patient. And usually patients are different, so you can't necessarily generalize in a group of what pills you want to take or this or that. And quite frankly, most people don't want to take a pill. They'd rather find a way out of it. And so what I thought I would do today was talk about the importance of coronary disease, some of the pathology around it, and some of the weirder things that people don't really think about, and what you can do to prevent it from happening. Now, people just say diet and exercise. There you go. But why is that good? So we'll talk about why it's good, because I always find that if people have a bit of an understanding as to why what they're doing is making their heart better or preventing disease, then they're more likely to do it. Because if you just go in and see a doc and he just says, look, do this, and he walks out, you may not pay attention. But if you understand what it is, then that increases the likelihood, right? So, burden of disease, this is 2017. Worldwide there was about 18 million people died from cardiac disease, cardiovascular disease. It's about a third of all deaths over age 35. And it's really expensive. In Canada, in 2015, there was, someone died from a heart disease or stroke about every 7 minutes, and that's probably more frequent now, right? The clock's probably down to 5 minutes or something. 9 out of 10 Canadians have at least one risk factor for stroke, and 40% have 3 or 4, right? That's heart disease or stroke. And so what that really tells us is that we're going to be busy, and we've got this great burden of coronary disease which is coming, that if we don't do something on a sort of population level, we'll never be able to control it on an individual level, right? Talking a little more, first of all, diabetes and cardiovascular disease. You can't be a cardiologist these days without paying some attention to diabetes. They're intertwined, so people with diabetes are 2 to 4 times more likely to develop cardiovascular disease than without. And the real scary part is that 50% of patients with diabetes die from cardiovascular disease, right? So that's why if we have diabetes or if we're at risk of diabetes, what we really want to do is prevent that from getting worse or potentially even making it better, right? So that way we won't have those dreaded complications, okay? And in terms of diabetes, this is 2017, but if you look here, well, let's take the 65 to 70-year-olds, obviously older than everybody else here, but 65 to 74, about 17% of men have diabetes, and about 13% of women have diabetes. And those folks, half of them are going to succumb from cardiovascular disease if we don't do the right things, right? So this is really important for us to try and fix, right? It's not just the sugar, as some people used to say, I got a bit of the sugar. No, it's much more than that. In fact, there was a study in 2018 in the New England Journal of Medicine, and it essentially looked at people that had diabetes and no coronary disease, or people that had coronary disease and no diabetes. So the sort of parameter or the simile would be that I have a twin brother. Let's say he had diabetes sort of a year or two ago, and I just had my heart attack today. The chance that one of us would have a heart attack in the next 8 years is the same from that study. And I just blocked an artery, and he just has high sugar. So that's how bad diabetes is, right? Canadian Cardiovascular Society, more than 2 million people. So basically, 1 in 18 people in Canada have heart disease. So that's a big quality of life issue. It's expensive, $30 billion a year. And it's the leading cause of premature death among women in Canada, actually. Which you don't think about, right? Normally people just think about the guy, right? So I guess really what I'm trying to sort of say here is that when it comes to cardiovascular disease, right? Like what's the point? And I guess the point is like don't be in denial, right? And for those of you that don't know, that's a Nile crocodile. The other point of this slide is this is why I got into medicine, because I could never make it as a comedian. But cardiovascular disease, it's common. We can all be affected. But the good thing is we can do something about it to prevent it, right? And so hopefully that's what we'll do, and we'll understand why we're doing it. So the common view of coronary disease is just this. This is the heart vessels. That's the left anterior descending artery. This person has a tight blockage in the proximal LAD. That's called a widowmaker. And so what we usually think about coronary disease is you go to the hospital, you go in for an angiogram, there's a tight blockage here. The doc, the interventional cardiologist, slips a wire across, like in between the blockage, and over that wire he threads this balloon, which is inside a stent, and the stent looks like your metal, like a fence, really, a metal fence, one of those fences. And it's crimps down on the balloon, and then put it in place, they blow up that balloon, right? Inflate the stent, open the blockage, take the balloon down, get out, and you're all done. Person's fixed. And for many people, it's truly incredible. I've had patients who've had rest angina, so chest pain with, if they burped, they had chest pain, and did this angiogram and they got better. And that's what we think, right? We think, geez, that's the best way to do it. Just cat the people, find the blockages, off you go. But the thing is, unfortunately, it's more complicated than that. So a typical case, now this is not a real case, it's not any individual around here or anything, but I just made it up from my experience of seeing people. So 60-year-old guy, chest pain at breakfast, typical male, tries to ignore it. His wife sort of tells him to stop it and calls 911 because she recognizes that he's ill. The paramedics will do ECG when you're at in the house. And if they recognize an ST elevation infarct or a certain type of dangerous myocardial infarct, and the computer agrees, or even if the computer doesn't agree, they'll send you straight to Kingston General Hospital. So that's what's called a primary PCI program, and that's been on the go for about 17 years or so. And so they would bypass Trenton Hospital or Belleville Hospital, or on the other side, Brockville Hospital, if that's close enough. And they take you straight to the cath lab at Kingston General Hospital, where they do an angiogram. And it's the best way. It saves time. it saves lives, and it actually also saves money for what that's worth. So this is a typical angiogram of someone like that. So this is the before, and this is the after. Now, whenever you get a medical thing, if you're ever going to do a test or your kids are doing medical tests, always pay attention to the arrows, right? Because what you'll see here is that this guy has a 99% blockage. See how that artery here just narrows down to nothing, and then it opens up and there's flow here. You'll also notice in this angiogram that there are little bites here and there in this artery, which says that a couple of things. First of all, this patient's having an acute myocardial infarct. If this doesn't get fixed, he's in big trouble because all of this muscle here, when this closes down completely, will die, right? And the other thing it tells us is that he has blockages in some of the other distal parts of this artery, just not severe. So then they do that last slide, which is they put the wire in, thread the balloon across, blow up, put the stent in. Looks great. You never even know there was a problem, right? He's better. A typical patient like this goes home within a day or two on a boatload of medications, and they're good. And so a typical guy like this is sitting down with some friends after and said, you know, like, I couldn't believe it. By the way, when you get these angiograms, they often give you a pre and post picture that you can look at. So, you know, they say, this is great. Look, I had all this stuff. But again, patient's wife, who's always smarter than the guy, she says, but hold on a second. You were running yesterday. The day before you had your heart attack, you were gone for a jog. How does a guy with this go for a jog? You can't. If you tried to go for a jog with something like that, you're going to be in big trouble, right? And the answer is that he didn't have that blockage when he had when he went for the jog, right? He had his artery there looked kind of like this. It just had some early blockages and stuff. And the point is about this is that 66% of heart attacks actually occur in arteries that have blockages less than 70%. Now, blockages, I mean atherosclerosis, easy term to remember. That's on the basis of autopsy studies, actually. So only 33% of your heart attacks occur in the severe blockages, but 2/3 of them occur in the blockages that are only mild to moderate. Okay, so really, that gives you a bit of pause, right? Because 60-year-old guy, you're going to have some early stuff. You will have atherosclerosis. So often when I see patients in the hospital or in the emergency department or in my clinic, they come in with discomfort or whatever. What I'm thinking about is two things. First of all, do they have a flow-limiting lesion, right? Do they have a tight blockage that's like this, right? Causes exertional symptoms. You know, the person with this is a circumflex artery. That's your number 3 most important artery. This is your LAD. This is your number 1. This person is gonna have chest pain when they do stuff, right? Open up with a stent, you're great, right? You'll only prevent 1/3 of infarcts if you fix this, right? They could have infarcts over here or at these little narrowings that are present. So you can fix the flow limiting lesions with stents or with medications, right? But the non-flow limiting lesions, you can't fix the non-flow limiting lesions with balloons or stents. And the reason why is that if you tried to fix every 30 to 50 to 70% narrowing, the procedural complication rate and the downstream complication rate would kill more people than it would help by fixing every artery. So this is an example of that. This comes out of a circulation article a few years ago. And this was a group in Japan, went through all their angiograms to find somebody that had 3 or 4 angiograms within about a year and a half. And this fellow had 4 angiograms about 4 months apart each time. The last one, I don't know if you can see this from the back, but the last one you can see here that there's a severe blockage. That's a 99% blockage in that fellow's artery right there. But this is the same spot, the same picture taken 4 months, 8 months, and about 12 months prior, right? And what it shows is that, look, there's only sort of mild to moderate blockages there, right? There, and there. And by blockages, of course, I mean atherosclerosis. And so the question would be is that, like the cynic might say, well, why didn't they just stent that the first time? Because then you would have prevented this from happening. And the problem is we can't, if we tried to stent that, well, why wouldn't we stent this one over here and this one over here, you know, and over here? You'd put stents in the whole thing. We can't predict when these mild to moderate blockages are going to break. All we can do is put you on medications, if needed, and do lifestyle maneuvers to prevent the blockages from getting worse, okay? That actually goes to a clinical study, or 2 clinical studies, that shows that even in patients who have severe-ish blockages, who have stable symptoms, there was a study called COURAGE and a study called ischemia, and what they found was that if your symptoms are stable and you've got a tight blockage, we can treat you with medications, or balloons and stents, and you have equal outcomes at the end of 3 or 4 years, right? Because what we're really trying to do is treat those non-severe blockages, because the non-severe blockages, A, can't be fixed with stents, and B, get better with medications and lifestyle. So that's kind of what we're talking about here. So the question is, how do we prevent these blockages or the atherosclerosis from developing? And to some degree, we can't. Like, some of this stuff is just a function of age. You start developing early atherosclerosis in your 20s and 40s, which slowly gets worse over time, depending on your age and risk factors, right? And over time, some of these lesions will result in angina or an infarct. And so what I'd like to talk about the rest of the time is, what can we do to prevent that from happening, right? Because if you're over 60, you probably got some early stuff that you might be able to fix, okay? So what causes atherosclerosis? Well, there's the easy ones, right? The smoking, the family history, the high blood pressure, cholesterol, diabetes. If you had a previous heart attack or stroke, you're more likely to get another one, right? But if we take out the ones that we can't do anything about, so we just left with the smoking, the high blood pressure, cholesterol, and diabetes. Looking at smoking, I'm not going to spend too much time talking about that because that's a real tough thing. People that smoke, most people that I talk to who smoke want to quit smoking and try multiple times, and eventually they usually succeed, but it is challenging. And I'm not about to start preaching to people about how they have to quit smoking. Do your best. There are medications which work, but that clearly is one way to prevent your coronary disease from getting worse or even occurring. If we look though at the high blood pressure, the cholesterol, and the diabetes, really the question here is that what causes high blood pressure, cholesterol, and diabetes? Well, that's more the other factors, right? The things like sedentary lifestyle, stressful lifestyle, and obesity. Because those tend to cause these other factors that we recognize more readily as a cause of heart disease and stroke. Stressful lifestyle, I think that was addressed a month ago, right? You know, Dr. McPherson is a better guy to talk about stress than me, because I should probably talk to him. But this is recorded, isn't it? So, but if we talk about sedentary lifestyle and obesity, what can we try to do to get that better, right? So if we talk about lifestyle, not having a sedentary lifestyle, we should have a lifestyle that's, you know, sort of more appropriate to cardiac health, to making us better. And, you know, looking around here, you guys are mostly probably a little bit older than me, so I'm not sure if you think about lifestyle with this, but this is not what I was thinking, okay? This is not lifestyle. That's not the lifestyle I'm talking about. But the big thing is walking. Walking or walking-like activities, arguably the best activity you could do. It doesn't stress your joints, right? You start slow, it doesn't, as long as you do it in a mild to moderate manner, it has excellent effects on you. It's actually, walking 20 minutes a day, 4 to 5 days a week is the same as taking an extra blood pressure pill. So I have patients who will walk, and next thing you know, they come in because their blood pressure is low. We can stop one of their pills, and they don't need it because their blood pressure is better. It can reduce stress, improve diabetes, but how does it do that, right? Because if this is all I was going to talk about, I'm probably wasting your time, because like we all know that walking is good, right? Well, so one thing is exercise can delay diabetes. So what happens when you exercise? So normally when you exercise, your muscles do 2 things. First of all, they eat the stored sugar in your muscles, and they'll also eat fat as you're exercising. And the type of fat they want to eat, like the free fatty acids and the triglycerides, that's stuff that wants to go in your heart. Because they've become deplete now of sugar, and because they've changed, they change from a cellular point of view. And for the next day, those muscles are able to eat sugar much easier than they used to be able to. In order for a muscle to eat sugar, it needs insulin to tell it to eat sugar. And as we get older, your muscle needs more and more insulin to make it work. It's kind of like it gets deaf, right? And the pancreas, which makes the insulin, has to shout louder, right? Well, when you do your exercise, your muscle becomes insulin sensitive. And so then the pancreas doesn't have to work so hard. It only has to make smaller amounts of insulin. What does that mean? It means your pancreas gets to rest. It kind of gets to live another day or rest another day. So you kind of delay diabetes by around a day. It's not quite a day, but it's around a day when you do your exercise for 20 to 40 minutes. And so that's why you'll see people who have diabetes who start walking, and next thing they tell you their blood sugar is better. They haven't changed their medications. Often they have to cut down on their insulin, right? So that's probably the best reason for exercise. There's other reasons though too. First of all, exercise can stimulate collateral flow, right? So for lack of a better term, you can grow your own bypass, which, take it from me and many of my patients, growing your own bypass is easier than getting one of the guys at Kingston to do it, because that's a little more invasive. It's not quite as fun as walking, right? Unless you're into that sort of thing. But so this is an example of that. Now this is a bit of a busy slide. All I'm going to say here is that these first slides here and here are what's called a root angiogram. They just show that this person's heart is normal. This guy's a normal functioning heart. It thickens normally. It's never had an infarct or anything like that. Right here, they did an angiogram. And this is your number 3 most important artery, called your circumflex. This little stub here, I don't know if you can see it, this is your number 1 most important artery, your LAD. It stops right there. This is a widowmaker lesion, right? This guy should be either dead or have a great big heart attack right here, okay? But why is it that the heart's thickened normally? It has not had any damage. And the reason why is when they inject it in the other artery, the right coronary artery, so that's the second most important artery, what you'll see is the blood comes down here. This guy's grown his own bypasses, and he fills his LAD from the bottom up. So this person will have a little bit of angina, right? Because it takes longer for the blood to go this way. He'll get some chest pain when they walk, but it won't be too bad. His heart function is still normal. He's not going to die from it, right? So this person, he was fated to have a widowmaker lesion, fated to probably have a really high chance of death on that day, but because of his collateral flow, likely precipitated by walking, he probably didn't even know he had a heart attack. Yeah, so that's why the walk-in is so important. In fact, that explains why often older patients will survive a heart attack better than younger patients, because the older guys and women have grown a few bypasses, right? They've grown some collateral flow where sort of like a 35-year-old, they don't have any, right? They get in big trouble, right? So that's why the walk-in is there. And now, if we talk about obesity, obesity, believe it or not, can decrease cancer rates, decreases heart disease, decreases arthritis. I don't know if we're going to get one of the orthopods to talk to us at some time, but for every pound you lose, you reduce the pressure on your knees by 4 pounds. So there's many people that are waiting for knee surgery or have painful knees, and they drop 10 pounds, and their pain goes away, right? Right? I'm not an orthopod, so that's all I'm going to say. But when it comes to weight loss, there's bad news and there's good news, right? Because let's face it, if weight loss was easy, we all wouldn't, we'd all look fantastic. Right? So it was easy, we'd all have perfect BMIs, low rates of diabetes, stroke, coronary disease, hypertension. Be like we'd be like Brad Pitt, right? And his wife going around, That's not going to happen. I better stop there. But anyway, but it's challenging. Now this is a picture of fat cells, okay? And this is the big ball of fat in there, or adipose. And here's the nucleus and stuff like that. And the point is that we used to think that fat adipose cells, you were born with a certain number of adipose cells and that was it. That's all you got, that was it. And that's completely wrong. Adipose cells can multiply quickly, very quickly actually. So as you gain weight and eat more, your body will make room for that. It'll grow extra cells for you to put stuff in. And the flip side, though, is that when you fast or when you lose weight, those cells, they don't die, they just shrink. They just sit around there waiting for you to lose your, right? To have that cookie, right? And the problem is that, but that's science that really, because you know how people would say, I can't even look at food because when I look at food and I'm losing weight, it goes right back. And they were true. They were right. They were 100% right. People would say, no, they're not, it's because the fat cells don't die. And if you have a moment where you take an extra chip or whatever, off you go. So it's challenging. It's very challenging. And the other thing too is that when you lose weight, right, as you lose weight, your metabolic rate slows down. This is another study from Circulation showed that people's metabolic rate slowed down as they lost weight. So it kind of makes you tired, relaxed. You don't want to do as much. Your body goes into kind of starvation mode so that the calories that you eat are used more efficiently. And the flip side of that is that when your metabolic rate is slower, the amount of food that you were able to eat here and lose weight, that same amount of food here will make you gain weight. Like, it's terrible, Watch, there's going to be a line up to McDonald's. They're like, forget it, we're out of here. This is enough. You've done it. But you can, I've really kind of pulled this up, haven't I? Well, but you can speed up your metabolic rate with exercise, right? But it's important to know these things because this is why you'll often lose 10 or 15 pounds and gradually you'll come back up, right? As well, when you have your fad diet, it's challenging. The fad diet, the weight tends to come back after your fad diet. And when we look at people that are able to keep weight off, so when you look at patients that have lost sort of 100 pounds, 200 pounds, things like that, the folks that stay at a lower weight, they use a food diary. So that's the key because it's just otherwise you'll cheat. You won't realize you're cheating, right? Now there is good news to weight loss, right? And really, the good news is that it's not an all or nothing affair, right? You talk about people that want to lose weight, myself, right? You want to lose 25 pounds, gee, I want to lose 5, and then you get miffed, and then you just forget it, I'm going to McDonald's, right? That's not the case. It's not an all or nothing thing. And even if you lose some weight, it's actually beneficial. So there's a couple of really good physician-based websites in the United States predominantly that talk about this. And so one of them, which is Rethink Obesity, they point out that, so what happens, let's say you only lose 0 to 5% of your weight, of your muscle, of your body fat. You're still going to improve your hypertension, and you're still going to improve your blood sugar. So even if you get a small amount, 5 pounds, 4 pounds, that will get better, right? Every kilogram you lose, so every 2.2 pounds is on average equal to 1 millimeter mercury. So let's say you're 140 millimeters mercury and you want to get to say 130, well then you got to lose 10 kilograms, which is 20 pounds. But even if you lost 5 kilograms or 3 kilograms, that's actually makes a beneficial effect predominantly for your stroke risk. Because remember, stroke risk, the number 1, number 2, and number 3 risks for stroke we often talk about are high blood pressure, and high blood pressure, right? So even losing a few pounds helps that blood pressure, right? Now, if you lose more, 5 to 10, you can prevent diabetes, non-alcoholic fatty liver disease, dyslipidemia. 10 to 15, you can reduce cardiovascular disease, steatosis, that's the more progressive form of fatty liver disease. And then greater than 15%, people's diabetes goes away, your mortality gets better, and your heart failure with preserved ejection fraction gets better. So it's not all bad, but I think it's important to recognize that when we go to lose weight, set a goal, but if you don't get to the goal, you haven't failed, because you're still making beneficial effects, right? Is the big thing. So yeah, even mild to moderate has beneficial effect. And the other point is that even in the patients that can't lose any weight, but they're more active, just being more active and doing that exercise, that's still beneficial, right? Because remember, what are you doing when you exercise? A, you're helping your insulin sensitivity. You're helping to delay diabetes. B, you're helping to grow those collaterals. C, you're burning up that fat stuff that you don't want to go elsewhere, that certain type of triglycerides and free fatty acids. So it's still worthwhile. In terms of type of diet, I'm not going to spend too much time talking about the type of diets because the dieting thing is a bit challenging. Essentially, caloric intake is the biggest predictor. So a study in the New England Journal several years ago looked at 3 or 4 different diets. And essentially, once you control for the amount of calories that the person eats, that describes all your weight loss. It's calories in, calories out, right? Just, certain diets you can lose weight a bit faster, certain diets a bit slower, but it's really calorie in, calorie out. If you had to sort of say which type of diet is more beneficial on top of everything being equal, plant-based diet's probably the best. It's very hard, but I would suggest it's the best. In fact, there's Dr. Theodoro, who she's a Belleville native, and she did her undergrad and a PhD, and then she did internal medicine with me actually in Kingston. And then she came to Belleville, was in the ICU with me for a long time, and then now she has a plant-based medicine specialty that she does plant-based medicine with, and it's very, very interesting. It is arguably the best diet. It's also the hardest one to do, but if you can get into it, it's great. Vegetarian, Mediterranean, I'm not a fan of carnivore diets. It's not good in your cholesterols, and our bowels are meant to be like herbivores or vegetarians. We're not like, we've got a big long intestinal tract, which is more fit for non-carnivores. That's, again, different. So how do you assess your risk? Well, first of all, you got to decide if you're primary prevention or secondary prevention, right? So what are they? Well, secondary prevention means you've already had an event. And I see a bunch of my patients here, and I could, some of them, they've had an event, right? So secondary prevention, you don't want it to happen again, right? So your previous event could be your diabetes, heart attack, those sort of things. The lifestyle measures still work. In fact, they're, I think, as important, if not more important, than in folks that are going for secondary prevention, right? But then obviously medical therapy is recommended. And the point of that is that aggressive medical therapy is very valuable. So getting yourself to the targets that your doctor says and that you guys want to work to really helps. So this was a case of patients who had diabetes and were at risk for having coronary events. And what they found was that if they got them to targets, they either did the sort of standard, this was back in sort of 1999-ish type thing, and if they got them to targets, instead of just doing the standard thing that they used to do back then, intensive therapy reduced your risk of an event by about half, right? So that's why we're sticklers for checking your cholesterol and trying to get your blood pressure under control and things like that. And make sure you do your walking, right? So, it's just wonderful. So, okay, primary prevention. I just got a text from my daughter. There you go. Primary prevention. Now's the stress, right? Don't check my blood pressure. No. So primary prevention, you haven't had an event yet, and you'd prefer not to have an event, right? And so in primary prevention, it's a little different. The question with those folks is, what can you do to assess your risk? And this is really done with your family doc, right? Or your primary care, which is, there's risk scores like Framingham risk score, which involves sort of a visit, some blood work, physical exam. Some of them don't take into account family history, so you sort of multiply that risk by 1.5. And sometimes we'll do select testing like a coronary artery calcium score to see if you have early evidence of atherosclerosis, right? And on the basis of that, if you're low risk, intermediate risk, or high risk, then you decide with the doc what you want to do. But remember, for all of these folks, right, this is where exercise and the lifestyle things such as weight loss are so important, right? Because what you really want to do is lower your risk. Because remember, you're not really, you're worried about the tight blockages. But what's really going to get you, or more likely to, is those non-tight blockages that are treated with, medications if needed, but the lifestyle stuff, right? So decision aids, then your GP or someone like me, we go to the Canadian Cardiovascular Society guidelines, the Canadian Hypertension guidelines, to sort of give us evidence and information as to where we go. And that's what we do every single day, right? And I'm not going to talk about what those guidelines are because, it's good cure for insomnia. So.
I'll be expecting an email.
That's right, exactly. Yeah, yeah. So summary, I saw that Dr. McPherson and there was two of them, right? And they were like an hour. How did they talk for an hour? So it's a big burden of cardiovascular disease. We got population level and individual level. And what this allows us to do is talk about the population level, right? Because if we can all get a little more active, all lose a few pounds. I mean, if everybody lost 3 or 4 pounds, you would see that in 10 years in the difference in sort of hospitalization and stuff. It's a big burden of diabetes, which clearly predicts future events, right? And then the point is you can prevent or slow down our individual progression of cardiovascular disease, primarily through walking and weight loss. And even partial success in these activities results in reduced risk. So like, what do? Well, I have one of those stationary bikes that I ride, right? And then I also have a treadmill that when I read my echoes, I walk on my treadmill, right? And then I actually joined Weight Watchers so that I could count my calories, right? To lose some weight, because unless you have a food, for me, unless I have a food diary, you blow it out. It doesn't work, right? And the point is even partial success in these things can result in reduced risk. And you can work with the primary caregiver for prevention. And I think that's about it. If you want any questions, it'd be great.
I'm going to trade microphones.
I understood that, but you missed